All right, let's take a look at some of the common symptoms that we might encounter while supporting a person who has a mental health diagnosis. And it's important for us to recognize that we're going to look at these in far more detail later on in Module 8. So this is just a brief introduction to the symptoms. We'll get into more specifics about how the symptoms may be manifested and in what constellations you might see them to represent particular disorders, again later on. The first one we want to talk about are delusions. Delusions are false beliefs, and to everybody other than the mental health consumer, they're clearly not true. The logic or evidence demonstrates that the belief itself is not true, and yet the consumer, when they have a delusion, really clings tightly to that belief. And some examples of delusions are thought control, where a person believes that an external force is controlling their thinking, persecution by others, or a perception that the person has ill health when all evidence suggests that they don't. Those are just three of them, and we'll look at more later on. Delusions are commonly associated with psychosis. When you hear that word psychosis, you should be thinking about the individual having a break with reality, having perceptions that are not accurate of what's going on in reality. And another one of the symptoms commonly associated with psychosis are hallucinations. Now, delusions were false beliefs. Hallucinations are false sensory perceptions. But to the individual, they are as real as the perceptions that you're having right now in terms of what you're seeing and hearing. The perceptions are usually auditory, but they can be also visual. Auditory meaning what they hear, visual obviously what we see, but they can involve any sense, including taste, smell, and touch, and in fact they can come in a combination. And so when we talk to people about their hallucinations, they will report to us they can't tell the difference most of the time between the real experiences and the hallucinated experiences. Delirium sometimes gets referred to as a break from reality as well, but it's not psychosis. Delirium is perhaps better understood as complete disorienting confusion. The individual doesn't perceive a false reality, they simply are disconnected from their current reality. And this can be caused by things like drugs, stress, fever, head injuries, or injury anywhere in the body because shock can cause it, withdrawal, dehydration, and hunger and malnutrition. These are usually transient episodes. The person normally stabilizes and returns to consciousness or awareness. So when we talk about levels of consciousness, we don't just, of course, talk about people being either unresponsive or responsive. There are people in between, of course, who can be confused, and some of them will be in that state of extraordinary confusion that we can call delirium. Now, you may have heard in the media about excited delirium, and it's something that's come to the forefront because it often is something that first responders would engage or have to deal with, because the individual becomes highly stressed by the interaction with the first responder. And that stress, combined with perhaps things like drug use or withdrawal or dehydration and malnutrition, can really aggravate that person's physical and psychological systems. Their heart rate will increase, their breathing will increase, their blood pressure may get dangerously high, and this is why we have to be particularly careful about the physiological and physical needs of people who are delirious. And we spoke about dementia earlier and said that it is commonly associated with people who are aging. Unlike delirium, it is not a transient condition. It's a condition where the person would normally progressively decline. It's a loss of cognitive functions and executive functions. The way the person's mind works and the way that their body works would tend to decline. Memory is the thing that we probably would notice first, but they would also lose, for example, the ability to recognize common objects or people, and the name for that is agnosia, A-G-N-O-S-I-A. They may also be able to lose some of the ability to speak or to speak at all, and that's called aphasia, A-P-H-A-S-I-A, or they may lose some of their ability to swallow, just as some examples, and that's called dysphagia, D-Y-S-P-H-A-G-I-A. And those are just some of the executive functions that a person will gradually lose. Depersonalization is essentially best described as a separation between a person's self, or their consciousness of themselves, and their body. People refer to it as an out-of-body experience, where they feel as though their mind is dissociated from their physical body. And I used the word dissociated on purpose. Normally, we are integrated. All of the things about us are associated perfectly or seamlessly. So we walk around feeling as though the person that we are, in terms of our psychological self, if you want to call it your soul or your personness, is physically sewn into your body, sort of like Peter Pan was sewn to his shadow. But when you are dissociated, those things that normally feel as though they're seamlessly integrated become separated. And so that's what's happening with depersonalization. People are referring to the idea that they can seem outside of their body and see what's going on from another perspective. Tics is the next one we want to talk about, or are the next one we want to talk about. And tics are basically involuntary motions or verbalizations. And these will look to the average outsider like jerky movements or grunts, and oftentimes we see them in young people, particularly young males, because there's something called a transient tic disorder, which can easily start in that age group of 14, 15, 16 years old. And so you may notice that your teenager is doing something like stretching the muscles in their jaw, or shrugging their shoulders, or sniffing repeatedly, and wonder why they're doing that. Well, that's the way a lot of tics look. The person may suddenly turn their head to the side, or make high-pitched noises or grunts like or that sort of thing. In the media, we hear about people swearing, and that does happen, or any number of words may be spoken. Although that's a rare form of this, they can indeed be combined with the other forms of tics. Now, people can have simple tics where they do one thing at a time, or complex tics where they put a series of particular motions in a row. For example, a person might get out of their chair and throw something, or they might make a strange series of motions that don't seem to be relevant. One individual I worked with would get out of his chair, stand up, clap his hands against the table, sit down, and pull the chair in. And those 5 or 6 motions together were just a common pattern for that person. One of the things we want to understand is that the individual who is having tics is normally aware of the fact that they're having these tics. And that might seem to people to mean that they should have control over it. But our consciousness is not the same as ability for us to have voluntary control over behavior. And individuals, particularly younger individuals who have tic disorders, will have less control than somebody who's older and has more experience in terms of managing their tics. But even those who do have some element of control usually have a temporary control and need to eventually find a private or quiet spot where they can ventilate some of that tic energy. And if we don't allow them to have that opportunity, the tics can come out all at once and almost be explosive and very disruptive. People can occasionally be violent when they go through tics. I worked with one individual who would walk up and smack a stranger, sometimes very spontaneously. And these people had done nothing to him, and he felt absolutely terrible, and was because he would get in trouble initially before we understood what the diagnosis was. His behavior after the tic was often very disruptive. When we found out what was going on and structured things so that he was able to go and ventilate some of that tic energy at a time or in a place that was more suitable, we saw a dramatic reduction in that type of behavior. Let's continue talking about symptoms. Obsessions are the next ones we want to talk about. And obsessions are thoughts, fixated and distorted thinking on a particular topic. And the individual here is having significant disruptions in their life because they think about this particular area of thought so much. Germs and cleanliness are a common obsession, and you may be familiar with the story of Howard Hughes, the American billionaire who was so concerned about cleanliness and germs that he refused to come out of his room. Or perhaps you're familiar with something that's happening on a lot of reality TV these days, focus on hoarding. You may have also heard in the news about celebrities who had stalkers. Now, obsessions are very fine line. Many of you may, for example, have a passion for collecting and have filled your home or spent considerable money on a particular collectible. If you have gone past a point where that is significantly impairing your lifestyle, for example, you're spending the rent to do this, or you're letting your children suffer in order to fulfill that obsession, that's where we would start to think about it as more than a habit or a hobby and now becoming a symptom. Compulsions are often seen alongside of obsessions. Compulsions are behaviors, whereas obsessions are thinking patterns. And a compulsion is a nearly irresistible urge to perform specific behaviors, often leading to very disruptive routines. So hand washing repetitively might go along with, for example, the germ obsession, where a person washes their hands so often that they literally have hurt their skin. Compulsions are often associated with obsessive compulsive disorder, but they can also be part of other disorders, such as, for example, crystal meth addiction. And some other examples of compulsions are things like people having to turn light switches off an odd number of times, or having to follow a particular route back and forth to every place a person goes. And these things can start to detract. A case I became familiar with was an individual who reported that they had to follow any car that they saw that had an out-of-state license plate, and this was an American. And they would sometimes cross lines of traffic to make that U-turn, or they would follow people for hours at a time, often ending up in a completely different state as a result. We often think about symptoms as things that people do that are unusual or harmful, but we should also think about what people don't do as a result of mental health needs. And this can be manifested as lethargy or as negative symptoms. And lethargy is perhaps best described as a lack of appetite or a lack of energy. The person may seem lazy, or they may be very boring to be around. Things that they used to take pleasure in may no longer please them. And negative symptoms refers to the absence or negating of things that people would normally do. It does not mean that they have a negative attitude. What it means is that, for example, they might stop getting out of bed, stop taking care of themselves. They might have what we call a flat affect, which means rather than showing the range of emotions that we would typically see, the individual simply has a very sort of bland and non-expressive way about them. The person may experience disruptions in sleep, libido, which is their sexual appetite, and their typical appetite or food appetite. They may sleep too much, that's called hypersomnia, too little, which is insomnia, or their routine of sleeping may completely be disturbed, and that's called dysomnia, spelt D-Y-S-S-O-M-N-I-A. Libido, as we said, is sexual appetite. Most of the time we think of libido as being decreased by mental health symptoms, and that in fact does happen. But it also is possible, for example, when a person might be in the manic phase of bipolar disorder, to have a higher than normal libido. And appetite can be reduced or enhanced by a mental health disorder, and each person would be different. For example, with major depressive disorder, some people's appetites go up and they eat more than they should, sort of drowning their sorrows with food, while others eat less and have lost their appetite entirely. Some people show that they're experiencing mental health symptoms in an indirect way by self-medicating, and they might self-medicate using legal substances like cigarettes, coffee, or alcohol, or even water, or illicit street drugs, or they might even use substances that are prescribed. In fact, sometimes they're prescribed for them, and they suddenly are just taking a larger dose of medication than they've had prescribed. So if you're supporting an individual with a mental health need, and you start to see them consuming something that could potentially be mood altering, and they're consuming it more, it's a sign that potentially they are reflecting to you that there's a mental health symptom. And that can be shown in external ways as intoxication or substance dependency as well. Suicidal ideations is the next thing we want to talk about. These are thoughts and particularly plans or envisioning of suicide. This is traditionally associated with major depressive disorder, but also with things like post-traumatic stress disorder and borderline personality disorder. And it's important for us to understand that suicide is not a typical response to day-to-day existence in Western culture. When a person has thoughts or threats of suicide, we should take that as a significant signal that there's a mental health issue. Somatic or physical symptoms is what we want to talk about next. Somatic symptoms are symptoms manifested as physical pain, illness, or physical arousal. In other words, the person's got something happening as a mental health issue, but it doesn't show up as a thought, a behavior, or a feeling. Instead, it shows up as a physical constellation of symptoms. And almost any type of illness you could be imagining can be replicated by this constellation of symptoms. So, for example, a person might resemble an individual who has diabetes or who has something like colitis. For example, some common psychosomatic disorders that you might have heard about are irritable bowel syndrome or chronic fatigue syndrome, which are essentially manifestations of stress on the person's brain physically represented. Now, this is something that whenever I speak about it, people sometimes sort of get a little bit on edge because they assume that we're describing this as a less serious health condition, saying something to the effect of, well, it's all in your head. And we couldn't be saying anything further from that. It doesn't really matter in terms of the seriousness of the illness as whether we say it's manifested in the pancreas or in the intestines or in the brain. It's still manifested within the body. And it still means that the person's experiencing real symptoms and they need serious help. It's just about identifying what sort of help is likely to make the biggest difference for an individual. So if you're working with people that have psychosomatic illness, you have to always be sensitive to the idea that they may perceive you as somehow dismissing or undervaluing what they're telling you. I want also for us to think about the fact that chances are each of us has had some somatic response to stress, things like tightened muscles or a stress headache. And all that's happening with somatization is that the individual's symptoms have become particularly severe or particularly chronic, and they have assembled in a way that resembles another illness. We want to talk as well about something called catatonia. When a person's catatonic, we typically think of them as being in a stupor, which means sort of a blank, passive, or impassive state. Their body is often frozen, or, and it's not written here, they may have hypermotor activity, like pacing really quickly or talking really quickly, and they seem unresponsive. This is sometimes a result of something like psychosis or schizophrenia, but it can also be a response to some of the older order of medications that people have taken, and sometimes it's aggravated by taking medications. I wanted to ask you to think a little bit about mental health crisis now in your journals. So using your journal, please take about 7 to 8 minutes to answer the following questions. To you, what does a mental health crisis look like? What causes people to experience mental health crisis? Are crises inevitable for mental health consumers? And if not, what can be done to prevent them? And what can be done to respond? Please take about 5 minutes to, or actually probably 7 to 8 minutes for this one, to write your answers, and about 5 minutes to review what others have written or to have a discussion. And we'll come back and talk about the realities of mental health crisis.